I'm going to discuss about this management of acute exacerbation of asthma in children. But before going to that particular topic, let's recapitulate what are the basic classification, what are the basic types of asthma. Asthma is mild persistent, mild intermittent, mild persistent, moderate persistent, severe persistent, and acute exacerbation. In mild intermittent case, the frequency is less than twice in a month or more than once or twice attack all over the year. This is intermittent. The mild persistent it is more than twice in a month, but less than once or twice in a week. Moderate persistent is more than twice in a week. Severe persistent, which present almost all over the week, throughout the week. Parents complain that throughout the year, the complaint regarding this cough, respiratory distress, running nose, etc. is present up to my bed. And rest one is the acute exacerbation. So, who are the most vulnerable groups in this category? They are the severe persistent group and the moderate persistent group. Now, we can confuse you. What are the conditions? Like the corona nowadays, influenza, acute bronchiolitis from the respiratory syncytial virus or Coxsackie virus, and sometimes some anaphylactic reaction, where same type of presentation you can get. So, what are the clinical presentation of acute severe asthma? This is difficulty in breathing, difficulty in speaking. If we count the word in a phrase, in that case, it is almost one word in a phrase. There may be in more advanced stage, there may be pallor, maybe cyanosis due to hypoxia, there are stridor, there are the accessory respiratory muscles, they are overactive, they are in more severe case, cramping may be present. So, in that case, what you will do, your decision will depend at which level you are present. As I am discussing here, this point is extended from metropolitan to the bottom, remote hardest village of India. So, in rural area, you have to think what are the modalities present with your hand. Suppose there is no oxygen availability. So what will be your management? There is no inhaler, there is no nebulizer. What will be your management? From that standpoint, this is very practical approach. You have to decide your treatment. Suppose there is nothing within your hand. What you can do? You can add some oral medicine like salbutamol or terbutaline, bronchodilators. These are the rescue drugs, and the preventer like oral steroid, sometimes intravenous steroid, sometimes deriphyllin is almost available, theophylline groups. You can add in that case, and you can send or refer the patient to the higher center. Suppose you are in a center where there is nebulizer machine, there is oxygen pulse oximetry, availability of oxygen, then don't give this steroid everything at a fast time. Start with bronchodilator with nebulizer machine, and it is better to add hypertonic sodium or normal saline solution, that is 3% saline solution for the nebulization purpose. You can add a patropium bromide combination along with the salbutamol, salmeterol, rather it is long-acting beta agonist, salmeterol, and so it is practically irrational use of nebulizer form of this refuse form of this budesonide or this fluticasone steroids, but you can add. And for quick release, prompt release, what you can do? Administration, inhalation, that is nebulizer application of adrenaline. If adrenaline is available, you can add adrenaline. Oxygen, moist oxygen, 5 liters per minute, universe. Add 1 oxygen mask or oxygen hood according to each group, whatever. Otherwise, in all the age groups, you can use the nasal strong, and along with that, encourage the patient to keep in propped up position, allow some what if like fluid type of medication so that hydration is okay. If you add saline, no problem. If there is fever, add antibiotic. Otherwise, no role of antibiotic. If in this case, with the nebulization, improvement is not so better, you can add the oral steroid or intravenous steroid. In this situation, add steroid in later stage. In higher center, suppose you are in higher center, check the oxygen saturation and do all other things as already I have described at par with level 2 or level 1 this past 2 tier hospital level. And in higher center, you can monitor, you can add the fluids and drugs to infusion pump, and if required, very rare case, you can send the baby in ventilator. But it is very rare case. Acute exacerbation, most of the time it is not needed. So, what are the drugs to sum up? It is the salmeterol, it is the patropium bromide, it is the theophylline, it is the hypertonic sodium solution, and the steroids, intravenous, oral, and sometimes in nebulizer form. These are the medications. Now, when the patient is better, how you will see? You can see with the oxygen saturation, his comfort is gone, his discomfort is gone, or our stridor is not present, branching is not present, the skin color is better, hydration is okay, and he is taking breath now in better way, but still wheezing is there. You can switch down to oral medication. In oral medications with inhaler, you should use this salmeterol and this steroid inhaler as a preventer. Here the role of steroid as a preventer with the fluticasone or the budesonide. In case of fluticasone, you can use fluticasone curate. Nowadays it is much more recommended. Combination therapy is also available, and along with that, this is the first line. Along with that, you can use the leukotriene inhibitors. But at this point, we should again recollect that leukotriene inhibitors, in case of mild intermittent or moderate intermittent in regular practice, we frequently across, and we do prescribe, as there is plenty medicines available in the market with the leukotriene inhibitors, and this levocetirizine type of or dextrobenadine type of combination, which is completely irrational combination. So don't allow that part. If at all you have to add these leukotrienes, first try with intranasal steroid. Then, if it is not improved, add these leukotrienes separately, with 4 milligrams, 5 milligrams, 10 milligrams, as you think, as you judge, separately, not with the levocetirizine. This is very important point. After this follow-up care management, it's a good hydration. You have to counsel this patient in case of boys, in case of the passive smokers, if there is smoking, the dust allergy, the home allergy, allergens that there, the role of allergy is very important, and the house condition, in case of carpet, in the indoor condition, there is outdoor condition, everything, and the seasonal condition, and the playground, everything is important to count for the prevention of that patient, to control the acute exacerbation of the patient, and elimination of some foods, at least for 1 year, if the allergy test is done. In this record, we have to think about the comorbidity. Also, there is about this GERD and this allergic rhinitis. These are almost 60 to 70% comorbid conditions. So we have to think and treat in that line also. In this regard, again, I want to add one very important thing, which is my point of research. And if you search with these topics, the intranasal steroid in asthma, with my name, Dr. Rajatsubhra without any space, Mukhopadhyay, you can find my articles and you can see there a specific type of therapy I have mentioned, which is called on-demand intranasal steroid therapy of Rajatsubhra. Because this is on-demand, because when you are controlling this patient, you are switching off the other drugs, the inhaler drugs, you are thinking the cost can be effective to the patient. You are in a remote area, the patient's conditions, economical condition is not so good, they are not affordable, the higher side, the costlier medicines with inhalers, which is now cost about 300 to 400 rupees. You are thinking the alternative therapy, you can use this intranasal steroid, but as book teaching, the intranasal steroid in case of is allergic rhinitis, it is continuous. If it is mild in the moderate intermediate, continuous therapy. But here, what I have mentioned is on demand. But on demand on which basis? Along with the allergy test. Allergy test, after allergy test, which you can done with immunoblock, you can done with skin prick test, you can done with even serum allergy test, and you can advise accordingly. If it is more than 0.33 millimeter in reaction, the role is very effective. The cost is very minimum in that patient, and almost all the patients are free of acute exacerbation and the use of these inhalers. In that case, again, we have to think some other medications like this immunotherapy, which can be the prick therapy and skin prick therapy or the spirit therapy. So immunotherapy is after local titration, it can be done after that, allergy test. In this case, we have to think about this monoclonal antibody therapy, omalizumab and tralizumab. There are some medications which we can, where there is some comorbidity, like acute asthma with respiratory failure and recurrent condition in that case. But with already the medicine I have discussed in my life, I never have seen in my 22 years life of pediatric practice, I never have seen that I am switching any baby or referring any baby higher sector for the monoclonal antibody therapy. So allergy therapy, allergy control, and with my style, that is on-demand intranasal steroid therapy. If you are interested, you can contact with me. You can find in online directly. Everything is there. So I can guide you. So it is much more helpful to the poorer nation like our India.